And it's my pleasure to announce the next speaker, that is Professor David Needham, who now switched to the very known University of Southern Denmark. And he will introduce us into thermosensitive liposomes.
Thanks, Jan. So what I wanted to do today was provide 30 years of work that starts with a micro-scale evaluation of the properties of the material we use at the nanoscale. We've heard a lot about nanomaterials and nanocharacterization, and I just want to make the point that you can study something at the micro-scale and still provide information on its properties at the nanoscale. In this case, it's a giant lipid vesicle, and of course that then produces some treatment. So quickly, the outline will be some data on our micropipette studies that we've done since, that I've done since the early 80s with Evan Evans, on membrane mechanics, on phase transitions, permeability, adhesion, fusion. I won't discuss all those, but just some of the pertinent ones. And then the molecular exchange experiments we did with Lysolipid that actually prompted the idea of including it. So the thermosensitive liposome itself, and then just a quick overview of some of the in vitro studies, preclinical animal studies, and then human clinical trials with some information that actually is only a few days old, and lessons learned. So the micropipette manipulation started back in 1983 with Evan, and we asked the questions then: what are the composition, structure, property relationships that allow membranes to actually perform their functions in cells? And how can we then maybe use nature's encapsulation technology in possibly liposomes? And at the same time, we were in Vancouver. Peter, Terry, Papagopoulos, they were all making these liposomes, and we got into this a little later to try and explain some of the phenomena associated with drug retention, circulation half-lives, even fusion. So can we engineer new products? Here's a liposome. It's a giant lipid vesicle on the bottom of a microscope chamber. It's got sucrose inside and glucose outside, and it flaps around in the thermal breeze. When we actually aspirate that into a micropipette, we could measure the bending modulus. These are microatmospheres of suction pressure, which are only piconewtons worth of force at that tip of the pipette. But if we then aspirate the vesicle further, then you can see the projection increase, and we can actually measure the elastic modulus of something that's only 2 molecules thick. It turns out that that's somewhere between a gas and a liquid, and if we add cholesterol, it ends up as something like polyethylene. So some of the experiments we did in terms of thermal sensitivity. Here's a transition from liquid to solid, and there'll be a decrease in the area per molecule, and we see that in a single vesicle. If we look at the solid vesicle, there's an indication that there's actually a kink, which is a solid membrane having a grain and a grain boundary. And if we warm this up, go back again from the solid to the liquid, that little lumpy bumpy motion are some of those icebergs of lipid going past the pipette tip. So we're going back through a mixed phase region in the phase diagram. So the vesicle undergoes a 25% area change, which is commensurate with the area per molecule that people measure in X-ray diffraction, and we saw it in a single vesicle. And it seems like the solidifying from the melt creates some microstructure. If we aspirate that frozen vesicle, we see how solid it is, and if we do this as a function of temperature, then we get a yield shear and a shear viscosity for this membrane. And what we said in 1987 was that the yield shear and shear viscosity effect reflect density and mobility of some crystal defects at in this plane of the membrane as they slide past each other during this shear experiment. This is what it feels like, and it actually feels like a plastic shopping bag. So this is a monolayer of diastereoyl phosphatidylcholine on a gas bubble. So then the lysolipid test, we were interested in how this molecule lysolipid may exchange with a phospholipid membrane. And if we expose the vesicle in the pipette, you see the projection length increase. So this is now a lysolipid at its CMC, 3 micromolar. So it's not enough to burst the vesicle or break it, it just causes this uptake. If we then bring in the bathing solution again, we can wash that back out. So it takes a while for that to get established. But the graph that we have on the right there shows the area percentage, which we calculate from the areas per molecule, and we can detect just a few mole percent of lysolipid in those membranes, and it saturates about 6%. If we carry on for another half an hour, we'll get a secondary transfer across the membrane. But the point was that if you do expose it to a lysolipid-free media, lysolipid leaves the bilayer, especially the outer monolayer, in this experiment rapidly in seconds. So this was the formulation then, and the thinking was that if lysolipid was trapped in the lipid bilayer, would it leave or form defects in the bilayer when the temperature was raised back to the transition or taken through that? And just like Yatvin and Weinstein and people before us, we chose DPPC as the host bilayer because of its transition at 41.5. We added this 10 mole percent monosteryl PC and then kept in the DSPE PEG because of the stabilizing component, the circulation half-life. It turns out it has another mechanism, as Hezi was alluding to. So here's the data for the percent of doxorubicin that's released from liposomes depending on the amount of monosteryl PC that's in the membrane. So pure DPPC is equivalent to this traditional thermal-sensitive liposome, and there is some release over 30 minutes, but it's fairly small. The initial burst release there is probably doxorubicin that's in its neutral form that's still in the membrane. So increasing the MSPC, you go past 8 mole percent and you get rapid release. In fact, if you go to these 10 mole percent or then even higher, almost all the drug, or at least 80%, comes out in the first 20 seconds. That release rate is faster than the rate at which a liposome goes through a tumor. So when we compared the traditional doxa-like liposome that wasn't designed to release its drug, it obviously didn't release hardly any drug in the 4-minute time point, raising it to these temperatures. But this lysolipid formulation, with the transition around 41, now brings the hyperthermia that the clinical professionals can achieve, 39 to 42 degrees for ovarian and prostate cancers, into the clinical hyperthermia range. So whereas the previous previous thermal-sensitive liposomes were in the sort of 43 to 44 range, they can now be heated. So this is an attempt to try and find out what the pore size of the permeability might be. So at the transition temperature, we've exchanged dithionite, we've loaded cisplatin, we've released doxorubicin, we've loaded manganese porphyrins. We've also loaded dextrans, which are 10,000 molecular weight, and so the radius of gyration there is 5 nanometers, but it didn't load a 40,000, which is 10. So the kind of circumstantial evidence here is that the pore size is somewhere between 5 nanometers and 10 nanometers, and these are equilibrium pores. We can take a liposome up to the transition temperature and hold it there, and whatever's in the external medium will exchange in. So the Bano, Marcel Bally's group, as well as Brad Wood. So Bano studied in mice and Wood actually in humans. And both of them have measured the half-life of doxorubicin in these liposomes as only 1 hour. The liposomes may exist longer, but the drug-to-lipid ratio is only a half-life of an hour. So, so there's some leakage in the bloodstream, even though in the in vitro experiments they're relatively stable at 37. When they go in the bloodstream, we've got some PEG on the surface, but maybe it's not enough. And there's some exchange. So what I think is happening is that the smallest particle on the planet, the proton, will actually leak out first. So we start at pH 4, but it goes up to 5.5 after the drug loading. And if the hydrogen ions go out, then the drug will follow it. And so I think that's the mechanism of leakage at 37. So the liposomes, the lesson here is liposomes do not retain their drug forever in the bloodstream, but they release it within a matter of seconds if they're at 41. So at 41 degrees, if there is a putative pore, it's actually stabilized by the PEG, we think. because we have data, just like Hezi showed, that if you don't have PEG present, there's a very slow, well, 2 or 3 minute release. But if you include PEG lipid at 1.3 mol% or greater, then you get the rapid release. So I think PEG lipids are actually part of stabilizing the pore, which is kind of an interesting accident. So the pores are stabilized, DOX comes out in seconds, the pore size is somewhere around 5 to 10 nanometers, and so that is the actual formulation. So it's a solid phase thermally sensitive biolayer. It contains this permeabilizing component, it's got a protective layer, and it's got the drug crystal, and then that's a TEM from Ickenstein. So to finish up just the preclinical studies, our rationale for hypothermia came from obviously Mark Dewhurst and his work. It turns out that hypothermia itself has some effects which are cytotoxic. If you heat high enough, you can obviously kill cells. At 48 degrees, the spectrum falls off red cells, but we can't go that high in a patient. So there are some cytotoxic effects of hypothermia. It actually does enhance chemotherapy. And it could be, again, permeability that does that and enhanced uptake. With liposomes, there's an increased blood flow. There's also increased permeability of the vascular system, and so there's increased liposome accumulation. And the new concept, though, was this rapid triggered drug release, which leads to a potentially increased therapeutic effect. So these were some of the first tumor growth curves that we ever tried to do in this FADU tumor at 5 milligrams per kilogram. So this is the rapidly growing tumor. It grows to 5 times tumor volume in 10 days. If we give free drug at the maximum tolerated dose without any heat, it's 12 days. So you have a 2-day growth delay. That's chemotherapy. If you apply heat, some of the tumors disappear, and the growth delay is now on average out to 18 days. If you do chemotherapy and hypothermia together, the growth delay is 22 days. How significant that is in humans, they're both approved. Some of the tumors obviously continue growing, but some of them do delay. In about 10 days, there's this decrease in tumors, if they decrease at all. If we take the doxil-like liposome, then there's clearly a very strong therapeutic effect. All the tumors disappeared, but they all grew back within 35 days. So here we're seeing this effect of probably the hyperthermia increasing the extravasation of liposomes into these tumors, and a slow release of the drug, whether that again is due to lipases in the tumor or due to hydrogen ions leaking out. The doxorubicin does actually come out, and it does actually have a therapeutic effect. But the striking result was that if we use the thermal-sensitive liposomes, so you heat the tumor, get it to 42 degrees, hold it there for 1 hour while you inject the thermal-sensitive liposomes, and all the tumors disappeared from that one treatment. This isn't multiple treatments. So they all disappeared at about the same rate as all the other tumors disappeared, but they stayed regressed for the whole 60 days of the study. So we're obviously very lucky that Mark had this tumor window chamber. Rakesh Jain popularized it, and Mark had it at the same time. And the overview of all the papers we've published on that since then is that hypothermia and these doxorubicin liposomes achieve this thermal steady state prior to TSL administration. And the whole tumor takes up the drug, and I'll show you a video in a minute. Fan Yuan actually did some studies where the tumor blood flow was found to slow down by a factor of 200 after this 1 hour treatment. And 24 hours after the treatment, there are no blood vessels left in the tumors. So hyperthermia increases vessel leakage. This is a study that actually Gaber, Papagopoulos' group, came to Dewhurst lab, and they did this together. At 34 degrees, just traditional non-thermally sensitive liposomes, there's absolutely no extravasation in this, even in this subcutaneous animal model. But if you turn on the heat, when you turn it on, there's massive extravasation. It's not homogeneous, it's actually heterogeneous, but this is the EPR effect turned on by hyperthermia. So look here. This is now injection of free doxorubicin in a tumor. On the left, you can see the green, which marks the blood vessels, and this is free dox. 20 minutes equals 20 seconds on this video equals 20 minutes of heating. That's how long free drug stays in the bloodstream and accumulates in the tumor. We'll let it run again. So that's a 2.5-minute half-life. So this is now the thermosensitive liposome. The green is the liposomes, and the red is doxorubicin. Again, 20 minutes of confocal heating. So this was just published in Cancer Research. So there's uptake by pericytes, endothelial cells, and basically this thermosensitive liposome at the phase transition temperature in the tumor shows intravascular drug release, and again, no lipid extravasation. If this tumor is not heated, there is no drug there. The liposomes don't extravasate, even in this animal model. We can all find animal models that are leaky, but animal models and maybe even human tumors that are not leaky, traditional liposomes, thermosensitive ones, are going to release the drug in the bloodstream. This is, again, only a local treatment. Okay, so where is the drug? And this is the thing that Hezi also pointed out, that if you extract with silver nitrate and chloroform, silver nitrate gives you the amount of drug that's bound to protein or still in the liposomes, and 1 hour after the treatment, when we take out the tumor, all the drug is still in the doxyl-like liposomes. But half of the drug is bound to DNA when we extract with chloroform for the LTSLs. Human clinical trials, just to finish up. So Celsion chose to do hepatocellular carcinoma mainly because it was a very deadly disease. Nobody had ever cured it, and there were plenty of people doing heating, which was by radiofrequency ablation. It turned out that was probably not the best choice. Then there's recurrent chest wall, where you can heat locally, and I'll show you those results too. So the phase 3 trial was 701 patients in 71 sites in 14 or 11 countries, and they kept receiving encouragement by the FDA to continue this. The primary endpoint was progression-free survival, or the extension of that compared to a control, which was radiofrequency alone. So this is the idea. Could thermodox expand the treatment zone for tumors in liver and kill the micrometastases that are around the edge by the residual heat that would then release the drug from the liposomes? So in the phase 1 trial, they actually got these results. So this is just a dose escalation, but they actually found that the progression-free survival extended from 32 days up to 180 days. That's a 500% increase in progression-free survival in a phase 1 study. So RFA plus this thermosensitive combination shows this dose response in this phase 1 trial for tumors that were just greater than 3 centimeters. Any tumor that's 3 centimeters or less, the radiofrequency ablation itself will actually kill the tumor. So in the chest wall, here's the clinicians and the scientists involved, and here's a lady receiving the treatment. 42 degrees. This is a BSD applicator. It's a 16 by 16 centimeters. And in fact, if the tumor is outside that heating zone, it acts as its own control, and they didn't get much response from those tumors. 30 milligrams per meter squared is less than the maximum tolerated dose. The MTD is 50. And this was the result for a lady who had no side effects. After pre-cycle 5, the tumor had completely disappeared. This was presented in 2008. And here's the second patient. And so there were 48% local responses, 17% in all the studies, 5 out of 29 complete responses from this phase 1 study. The Dignity trial, it's called. It continues now. Celsion have resurrected this trial and have continued it in several other sites. But the top-line data that came out in January was really disappointing for everybody involved. Celsion found that it didn't meet those progression-free survivals. It was hopefully going to be 33% or better than RFA alone, and it didn't meet that top-line data. So if you look at the pharmacokinetics, you may find out why. So they initially started with injecting the drug 15 minutes and then turned on the heat. So they heated a radiofrequency ablation heating for the first 12 minutes in the control arm plus the drug arm, and then intermittently for a period of up to, say, an hour or even longer. So if we look at the pharmacokinetics, you're losing just a little bit here before you heat, and then if you heat intermittently, what is the temperature in that tumor, and what is the temperature actually at the periphery where the micrometastases are that would actually grow back and cause the treatment to fail? So for the protocol for chest wall recurrence was even worse than this. The protocol says heat within 1 hour of achieving the finish of infusion. So if the person is in the medical oncology suite getting the infusion, and then it takes them some time to take them to radiation oncology suite, this is where the drug is going. It's being lost from the liposomes and lost from the bloodstream. So that treatment needs to be revised, and I would suggest the preferred protocol is what we've done throughout the history of this liposome, was heat first, raise the temperature of the tumor, and then keep heating while you inject the liposomes. So what is Celsian learning from this post hoc analysis? This is June 19th, June 20th, 2013 in Hungary. Riccardo Lencioni provided these statements. The duration of heat from the RFA procedure is a key factor. I almost want to say, no shit, Sherlock. Thermodox markedly improves PFS and survival in patients if their lesions undergo RFA for 45 minutes or more. 45 minutes to 90 minutes, 40% of the single lesion patients, overall survival improvement is 66%. If you went longer than 90 minutes, then of these patients, it almost doubled. And that's the 53% improvement. And if you don't heat, or if you heat less than 45 minutes, then it was no better than the control, which actually was 20% better than they expected because doctors were on the clock and they did it for 12 minutes instead of 6. So lessons learned: heat first, inject Thermodox, keep heating for an hour, kill the tumor. I hope you're recording this and actually Celsian might hear it. This is the, these were confocal stills. Let me just go back. These were stills taken through the tumor that shows that the stroma, the pericytes, the endothelial cells, the cancer have all received doxorubicin. And this is, people talk about bench to bedside. This is microscope to bedside. And all the people involved, thank you for your attention. And if you want to know what I really think, there's a chapter in Kinnan Park's book. Thank you.
Yeah, thanks a lot, David. We have time only for one short question. Please.
Can I ask, what's the specific method you use to test the Thermodox release? What's the method you test? For example, you use fluorescence signal from the dox?
Yeah, you can use a fluorescence signal or a change in absorbance.
Absorbance. Did you use cell culture experiments? For example, uptake of the dox?
No. There has been some cell culture uptake, yeah. That was Pavlenko actually has a paper on that. Sure, the cells take up the drug. In fact, the extent to which a tumor actually responds is dependent on its ability to take up the doxorubicin.
The graph you shows here, the method is not by cell culture method, right?
No. This is all in vivo.
Okay. Oh, right. Okay, thanks.
Okay, thank you again, David.
Yeah.